Good afternoon, everyone. I, Dr. Ajay Rana, Assistant Professor from the Department of Kaumarbhritya of Srimati Urmila Devi Ayurvedic Medical College, Hoshiarpur. Welcome everyone on another day of this webinar. First of all, I would like to thank our Chairman, Sir, Engineer Amberjit Singh Walia, Sir, for their consistent support for this webinar. I would also like to thank our Principal Ma'am, Dr. Meenakshi Ma'am, and our Vice Principal Ma'am, Dr. Sudheer Sharma, for their support and guidance. I would also like to thank the members of the coordinating committee for their efforts in conducting this series. Now I request our Vice Principal Ma'am, Dr. Sudheer Sharma, to say a few words on this session. Over to you, ma'am.
Thank you very much, sir. Good afternoon, everyone. A very warm welcome to everyone on the 10th day of Ayush Vibhodhini 2nd. Myself, Dr. Mridu Sharma, Vice Principal of Srimati Urmila Devi Ayurvedic College, would like to extend my thanks for support and cooperation to our respected Chairman, Sir, Engineer Amarjit Singh Walia, and Principal Dr. Meenakshi Nath. I would also like to appreciate the hard work of our coordinators, Dr. Deepika Minhas, Dr. Pooja Thakur, Dr. Sonika Jarayal, and Dr. Jyoti Saroa, who are managing everything very nicely. I would also like to thank and welcome our guest speaker, Dr. Sudheer Sharma, Assistant Professor in Kaumarbhritya in Government Ayurvedic College, Aknoor, Jammu. Thank you, sir, for accepting our invitation and guide us with your immense knowledge in your field. Thank you. Thank you very much, sir. Over to you, Ajay, sir.
Thank you, ma'am. Now, before moving forward, let me introduce today to our guest speaker, Dr. Sudheer Sharma. He is my batchmate in the PG studies for 3 years in SDM Hassan, Karnataka. He did his UG from Rajiv Gandhi University in Karnataka. He has done his PG studies from SDM College of Ayurveda from Rajiv Gandhi University. After that, he worked for 2.5 years in the DAB College, Jalandhar. And presently, he is working as an assistant professor in Government Ayurvedic Medical College, Aknoor, Jammu. He has also worked on the topic on the effect of Swarnamrit Prashna on Shaya. He has conducted various workshops and lectures on many topics of Kaumarbhritya. And also, I am very thankful to him for giving his precious time for our students. Hope this session will benefit the students in and understanding the topic. Over to you, Dr. Sudheer. You can start now.
Thank you, everyone. Firstly, I want to thank Principal Ma'am, Dr. Meenakshi Nath Ma'am, Chairman Sir, Shri Amarjit Singh Walia, Engineer Sir, and I want to thank my friend Ajay for inviting me and giving me opportunity to share my knowledge. So today's topic we're going to discuss is newborn examination. Because of technical difficulties, I'm not able to share the PPT with you. I'm conducting it with my mobile. I was unable to connect. So let's start with the topic without wasting any time. So we'll discuss in between. The first lesson will start with newborn examination. Our topic is newborn examination. So what is the aim of the newborn examination? It is we do it to describe and carry out the examination of the baby soon after the birth, and what are the objectives? To screen for malformations, to observe smooth transition from intrauterine life to extrauterine life, and to assess overall condition of the baby. So what are the minimum prerequisites required for the examination? Mother and baby together, warm room. Firstly, we have to manage the room. It should be warm. Thermometer should be there. Weighing scale, watch and watch with seconds, and stethoscope. These are the some requisites there. And firstly, the first examination baby go through is Apgar score. There are certain other things we will discuss later. The first one is Apgar score. What is Apgar score? We should know first. Apgar score is a quick assessment of the baby at the first and the 5th minute, and sometime on the 10th minute also. Why we do this? We do it to know the general condition of the baby, whether the baby transition is going very good or baby is having some breathing difficulty. So for that we do it in a way. So there are 5 domains, 5 parameters we discussed here. The Apgar, every word stands for something. APGAR. A stands for appearance. We give scorings for everything from 0 to 2, 0, 1 and 2. Like A stands for appearance, P stands for pulse, G stands for grimace, that means reflex irritability, A stands for activity, and S are for respiration. So we give scoring to each and everything like from 0, 1 and 2, then and finally we calculate it. Like for appearance we go like if the baby is cyanotic or pale all over, then we'll give scoring like 0. Means better is the baby and we give better scoring like 2. We give 1 scoring when baby is having peripheral sinus, when the central body is normal and the extremities are blue or cyanosed, we give score 1. And we give score number 2 when the whole body is pink, there is no cyanosis. And same way goes for pulse. If the pulse is 0, there is no response, then we will give scoring like 0, and we give scoring 1 if baby is having pulse rate less than 100. If it is more than 100 to 140, that is the normal pulse of the baby. Normal heart rate is 120 to 140, we'll discuss later. We'll give scoring 2 in this. Likewise, grimace, we'll check. How we'll check grimace? We'll insert when we do suction, when we do nasal suction or oral suction, we insert a suction catheter in the firstly in the oral cavity, then in the nasopharyngeal way. So when we put it, we will see the response of the baby, whether the baby is responding well. If there is no stimulation, there is no response to the stimulation, the scoring is 0. If baby grimace, means baby make some facial expressions but not able to cry, we give score 1. And 2 is when baby cries simultaneously or baby have coughing after we insert that catheter into the nose. And fourth one is APGA. Fourth one is activity. Activity we have to see if the baby is floppy, we give scoring like 0. If there is some flexion, because a newborn is having universal flexion, because all the muscles are flexed in the initial stage. If there is some flexion, we'll scoring 1. But and when the all the joints are flexed, like we said in universal flexion, we're scoring 2. And same way, it goes for respiration. If baby is apneic, if baby having some apnea in means cessation of breathing, we will give scoring 0. We will give score 1 if there is slow and irregular breathing. And same way, if baby is having strong cry, we give score 2. And finally, we calculate the score according to the condition of the baby, and then we'll finally decide what to do, which way we have to go. If the score is normal, if the score is 7 or more than 7, we will take it as a normal. We will take it as moderately low when the score is 4 to 6. In this condition, baby will be slow gasping condition. The score, if the score is 3 or less, we will take it as a very low. And further moving, these we move to vitals. How to check vitals? What are the normal vitals of the baby? The first thing is color. A normal newborn is normal newborn baby is pink pale color, and a extremely premature baby will be very red. In the color, then we have to assess cyanosis, because cyanosis is very important in the initial stage. If cyanosis is there, we have to give certain things, like we have to initiate a ventilation or we have to give oxygen. So assessment of color is very important. If the body is fully cyanosed, we can say peripheral cyanosis along with central cyanosis. That means we have to do some ventilation, or we have to give oxygen, or we have to move to bag and gradually we have to move to bag and mask ventilation or other chest compression. Like if there is only peripheral cyanosis, then we need not to worry, we can ignore it. It can be recovered by covering and giving heat to the baby, proper heating. And in the color, again we have to look for icterus, because the pathological jaundice, it appears on day 1 only, because we all know the physiological jaundice is physical jaundice comes to is accessible when on day 3. If it is on day 1 or day 2, it is pathological jaundice. Likewise, we have to record the temperature. Normal temperature is 36.5 to 37.5 because babies are more prone to hypothermia. So we have to take care of that. If baby having temperature little -5 less than like 36 to 30.5, we have to take it as a cold stress. And if below than 36 degrees Celsius, we have to take it as a hypothermia. And then accurate temperature to record it is through anal per anal region. And how we have to assess, we can check, we can compare the temperature between extremities and the abdomen. Next, respiratory rate. Normal respiratory rate of a newborn is 40 to 60 per minute in normal conditions, and pattern of breathing is completely different. Here pattern is abdominothoracic, like in adult we have thoraco-abdominal pattern, but here pattern is different. And mild cessation of breathing is means we can say a pause of few seconds is very normal. If breathing is periodic. What if this cessation of breathing is more than 20 seconds along with bradycardia and cyanosis? We have to worry because this is apnea of prematurity. Even if in mature uh, fully term babies, in certain conditions apnea will be there. So we have to take care of this. And if again here we can assess the baby, like if the heart rate, respiratory rate is sorry, if the heart rate is less than 100, then we have to move to normally 120 to 140 in a newborn. If heart rate is less than 100, we have to go for bag and mask, that we can say what we say ambu bag ventilation. If the heart rate is less than 60, then we have to move further. Along with the bag and mask ventilation, we have to add chest compression also. Next parameter is CRT. CRT is capillary refilling time. How we assess it? We have to blanch the skin of the baby like this, and we leave it. We have to press it, blanch it for 2 seconds, 2-3 seconds, and we have to leave it. A normal response is the blood will rush back within 2 seconds. But if it takes more than, if it takes 3 seconds or more than 3 seconds, we have to take this abnormal. This is a sign of shock. And moving further, next is neonatal reflexes. How we have to do it, and we will discuss some other important reflexes we have to check in the baby. The first one is Moro's reflex. Moro's reflex is how we have to do it. In this reflexes, we will see how we have to. One thing is we have to give stimulus, and how the baby will respond. This is to check the development of the brain development of the baby, whether the brain is intact or not, brain stem is intact or not. So like this, first one is Moro's reflex. How we have to do it? We have baby should be in the supine position, in a resting position, and we have to flex the neck, like it should touch the sternum like this, and baby should be in supine position, and then we will suddenly release it and catch the falling head. This is the stimulus we will give, and the normal baby, a term baby, will respond like uh, baby will extend his arms, open his abduct his shoulder, and open his hands, and followed by a cry. This is the normal response. But in sick babies, this is a very important one. In sick babies, baby who are having septicemia or neonatal jaundice, like in kernicterus, so this reflex will be in kernicterus. This reflex will be exaggerated, but in sick babies, their reflex will be diminished. Or in preterm babies, baby will not be able to abduct the shoulder and uh, open the arms and open the hand. We will slowly give some of the response of that. So, more reflex, if sometimes it is unilateral in certain conditions, like if baby is having of palsy or babies having fracture of clavicle or fracture of humerus, the response will be like one way, not both the limbs. The next is sucking and rooting response, sucking and rooting reflex. This is very important because for the feeding of the baby, if baby feeds, this response is very important. In the term babies, baby will be able to suck. How will check it? Rooting response. Examiner have to stroke the corner of the mouth with his finger like this. The baby will root back to the stimulus so as to suck it. So to put it in the mouth so as to suck it. This is a normal response. And when we'll clean the finger and we put in the mouth, we will start sucking it. This is a normal response. But in the many preterm babies or babies who are sick, this response is diminished, and in those conditions we have to give some alternative feedings, like we have to give nasogastric feed, or in extreme babies who are very sick we have to give IV lines. So this is very important to initiate the feeding. Next one is pull to sit. Pull to sit baby should be in supine position. We'll hold the arms of the baby and we'll try to pull it. Firstly, baby, the head will lag behind, and afterward we will try to maintain it in midline. The extensor, the flexor muscles of the neck will work, and the baby start doing like this. We will come along with the hand if we pull it, and then it will fall forward. So we will show some neck movements. But in sick babies, the neck will fall like lag behind. We will not try to bring it up. Next one is palm and plantar grasp. It will be elicited by if we stroke the ulnar end of the hand of the babies with the, if we stroke it like this, baby will catch it. This is palmar grasp, and plantar grasp in the same way. If we in the sole, if we give some stimulus, this is like Babinski. Baby will flex his flex his fingers of the foot. Next one is crossed extension response. The baby, this is illustrated by when baby is in supine position, we hold 1 feet of the baby like this, and we'll give some stimulus. With some stimulus, we will will tingle it, and what we'll do, baby will flex the because baby is not able to move this leg because we have holded it, and baby, what will we do? We will flex the other leg. Firstly, flex it and then try to hit it. Firstly, flex it, then extend it. Means like he's trying to hit the stimulus or hit the examiner's hand. So this is the cross extension. Next one is asymmetrical tonic reflex. This is illustrated by turning the baby's head to the one side. Baby in supine position, we turn the head to one side. What will baby will do? We will extend the arm to where the towards the face. Where the face is there, we will extend the arm, and towards the occipit, we will flex the arm. This is the normal response. Next one is symmetrical tonic neck reflex. This is checked by flexing the neck and extending the neck. This is when we flex the neck of the baby, the lower limb will be extended and the upper limb will be flexed. The same way, if we extend the neck of the baby, the lower limb will be flexed and the upper limb will be extended. The parachute reflex, it appears only by, this is not a neonate reflex, it appears 6 to 9 months. If we keep the baby in plantar suspension and suddenly lower him while the coach like this, and the baby will make some parachute like movement. We will extend his arm like this so as to protect him from falling. These are the reflexes, and then we have to do the head to toe examination. Firstly, we'll see head. First, we will see the general appearance of baby here from in head to toe examination. So general appearance of baby, as I told you, it is baby is in universal flexion. All the limbs are flexed like this. upper limbs, lower limbs, like elbow, shoulders are adducted, arms, knees, everything is in the flexion in the term baby. But in the preterm, this flexor tone is bit low, less like this, and in the extreme preterm, baby will be floppy. This is the general appearance. Then we have to go for we have to look for face. We have to look for dysmorphism and facial nerve injuries. Like dysmorphism means by looking at the baby, if there are some dysmorphic features like in Down syndrome, we can identify by just seeing the baby, and also we have to see for facial nerve injury. The mouth will drop to the side, and further after face we will move to head. And what are the things we have to examine? What are the things we have to notice? Firstly, important the fontanelle. Fontanelle and the normal dimensions 2.5 to 2.5 centimeter of the anterior fontanelle, but in certain condition it is elevated, in certain condition it is depressed, and in certain condition it is widely open, like in hypothyroidism, in Down syndrome, the anterior fontanelle will be widely open. It closes by 18 months, and the posterior fontanelle is like tip of the small finger. It closes by uh, about 1 or 2 weeks. Then we also look for caput saccharidium and cephalohematoma. What is caput saccharidium? Caput saccharidium is a collection of fluid, serious fluid collection that is not harmful, which is which is due to when during the delivery, when the presenting part of the head is continuously stroking to the internal pelvis of the mother, there will be collection of serious fluid. This is not very dangerous. We can ignore it and it will heal by 1 or 2 weeks. The next one is cephalohematoma. This may be due to some injury because there is collection of blood, like in the forceps delivery or in traumatic delivery, there will be injury, and there will be collection of blood, which is very harmful. This can lead to complications. We have to look for it. Next thing we look for eyes. I have to look for the corneal haziness, conjunctival hemorrhage that may be due to traumatic, and we have to look for cataract, glaucoma, and red reflex. And then we have to look for ear. What we see in ear, we will look for size, shape, and preauricular tags. Preauricular tags are when preauricular tags and pits are present, we have to scan for renal abnormalities because they emerge from the same germ layer. So we have to rule out renal abnormalities. Then we'll check for nose. We will look for discharges and choanal atresia. Choanal atresia when the nose is closed in the posterior because of some bony projection are like membranes closure. How we check it? If baby is not able to breathe, we'll insert suction catheter during initial steps, and then we'll look for mouth. We have to look for certain things like oral thrush, absent pearls, macroglossia, profuse frothing. Profuse frothing will be there in tracheoesophageal fistula. Not able to. Then we will look for neck. In the neck, we will look for sternocleidomastoid tumors, and we will check for thyroid enlargement. Then upper limb, we look for semen crease, which is present in Down syndrome. This crease will be like straight, and we'll look for clinodactyly and cametodactyly will be movement. And if in chest, we'll look for breathing pattern, like previously said, the pattern will be like abdominal thoracic, and then we have to look for retraction, like in respiratory distress syndrome. The intercostal muscles will withdraw inside when the baby is breathing. And further, next we will look for anal patency. We'll check if the baby is passed muco and meconium, then we need not to check. Baby did not pass, we can insert that suction to check anal patency. And then genitalia we have to look for. In genitalia we have to look for the penile length. If the penile length is less than 2 centimeter, then we have to further rule it out. We have to further go for further things, and we have to we have to ask for urine stream, and we have to rule out epispadiasis and hypospadiasis. And again we have to look for undescended testis, hernia, and phimosis, because physiological phimosis is common. We need not to treat. And in females we have to see labia majora, because in normal term baby labia majora covers the labia minora and clitoris completely, but in preterm baby labia majora is widely separated to expose labia minora and clitoris. And in lower limbs we have to look for varus and valgus deformity, where the lower limbs are inverted, like bent inverted inside or outside. And we have to also look for talipus equinovarus, which we also call clubfoot. And next we have to look for spine. We have to look for dimples, skin tags, because these might be the sign of meningocele. And we have to look for kyphoscoliosis extra. And in skin we have to look for, as we discussed earlier, cyanosis, bruising, traumatic delivery like petechiae, or peeling of the skin like we see in the postpartum babies, and jaundice and CRT. So next, finally, we have to see the danger sign. We have to explain the danger sign, or even on discharge. Even in baby in hospital, we have to see these certain danger signs, like if baby is not feeding well, if baby is less active than before, if baby is breathing fastly, or baby is having breathing gasping, and moderate to severe chest indrawing. Because in respiratory distress syndrome, baby will not be able to breathe easily, so use of intercostal muscle will be there. And we have to look for grunting and convulsions. We have to look for that can be due to hypoglycemia or some CNS disease. And if the baby is floppy or baby is stiff, both conditions are dangerous. And we have to look for temperature. We discussed earlier the normal temperature is 36.5 to 37.5. And again, during the abdominal examination, we have to look for the umbilicus. We have to see there should be, like, there should not be any discharge from there, or there should not be any redness, because it can lead to umbilical sepsis. If there are more than 10 skin pustules, that can lead to sepsis. And we have to look for umbilical stump bleeding. If it is there, we have to take measures to stop it. And also we have to check the anthropometry of the baby, like normal length of the baby is 50 centimeter, and we check it by an infantometer. But in baby who are having cerebral palsy or whose muscles are very flexed, we can check by segment, and then we can add it. Normal length is 15 centimeter. Then we have to check the head circumference and chest circumference. In the newborn baby, head circumference is bit larger. Like if chest circumference is 32, such as head circumference is 2 or 3 centimeter large, like it will be 35, and the normal weight of the bee is 2.8 to 3 kgs. Below than that, below like 2.5, we have to take it as a low birth baby. And if baby is showing any signs of infection, we have to go for RSS, like rapid sepsis screening, and we have to rule out if any infections are there by checking Ig ratio, by neutrophil count, ESR, and CRP, and certain other examinations we can do, certain other investigations we can do.
Dr. Sudheer. Hello, Dr. Sudheer.
Hello.
Hello.
Are you getting me?
Yes, I am getting.
So this is a brief introduction of neonatal examination. So I would love to thank the management and principal ma'am and my dear friend for giving me opportunity to explain. Over to you, Dr. Ajay. Thank you.
Thank you, Dr. Sudheer. Thank you for this presentation. Hope our students has gained something from it, and hope we will have more sessions in future. And lastly, I would like to thank everyone for listening this session patiently, and to have, and maybe next time we will have more sessions like this on more topics. And I hope in the future we will have more learnings. Thank you, everyone, and have a nice day. Thank you very much.
Thank you.